Hi, my name is Dr. Ross Hauser. Welcome to the Hauser Neck Center here in Fort Myers, Florida. Really interesting topic today, basilar invagination. So I'm going to try to make it simple and give you guys some alternatives to surgery, though the main treatment for basilar invagination previously has been surgery, and there definitely are cases that I refer for surgery. So basilar invagination with ventral brainstem compression. So is atlantoaxial instability the cause of basilar invagination? So basilar just means base of the head or base of the skull. So invagination means that something's invading the base of the skull, and what it is the dens of C2, the dens of C2. So see the hole there? That's called the foramen magnum. And I don't know if you guys can see it, but that's the dens of C2, that bone. The dens is what the atlas rotates around so we can rotate our head. The dens of C2, the dens of C2 is not supposed to go into this hole. When it goes into that hole, that's called basilar invagination. So I'm going to show some pictures. Dr. Goel is a neurosurgeon in India, and he's written a lot of interesting papers, and I have a couple of references here. But it's his belief that basilar invagination, the cause of it is atlantoaxial instability. Now, atlantoaxial instability means that the atlas is moving too much. So when the atlas moves too much, one of the things that can happen is that it can compress the jugular vein. When it compresses the jugular vein, and the jugular vein is the main drainage port through which the fluid in the brain drains. So 70% of the fluid in your brain is in the venous sinus or the venous compartment of the brain. 70% of the fluid is in the venous compartment. And when you sleep at night, the jugular veins are supposed to be completely open, so the brain drains, the brain drains, the brain drains. That's why when you wake up in the morning, you're supposed to be refreshed. Or in the middle of the afternoon, if you take a nap, right, just a power nap for 5 or 10 minutes, your brain drains, gets rid of toxins, the pressure goes down, and the brain feels refreshed, right? When you are waking up and you're not refreshed, or even if you take a nap in the middle of the afternoon and you're not refreshed, it's probably that your jugular veins aren't opening. Why aren't the jugular veins opening? It could be because of atlantoaxial instability. So atlantoaxial instability means there's ligament damage in the upper neck, and you would know that you might have it because you have clicking, popping, grinding in the upper neck, and you have tension up here. So you always have tension up there. It's probably the muscles are contracting back here to try to keep the atlas this way. The problem is, if the jugular veins are blocked, it can put pressure on the brain. It'll put pressure on the brain, and then the brain can sag, causing things such as cerebellar tonsillar ectopia or Chiari. Chiari and cerebellar tonsillar ectopia, again, is where the brain sags in this hole. So that's a problem, as well as the bone, the dens going into that hole, the foramen magnum. Both of those things can be caused by ligamentous cervical instability at the atlantoaxial or C1, C2 junction. And then what happens is, if the fluid can't flow, you're going to get all this fluid accumulating in the brain, so the brain tries to relieve the pressure by the brain sagging. And the only reason why I bring this up as it relates to basilar invagination, because basilar invagination, when I see it, the person normally has cerebellar tonsillar ectopia. In other words, the brain sags in the hole, or the cerebellum sags in this hole. So basilar invagination, I normally don't find it just by itself, right? So you could see right here where the dens is hitting the brainstem or the cranial-cervical junction here, that's basilar invagination. So it's boom right in there. And of course, the symptoms are going to be lessened by good posture. And when the person flexes the head, right, if they flex the head, that thing is going to be jammed right into there. So if you suspect you have basilar invagination, I'd recommend that you get a flexion extension MRI. And what we do in the office is called a digital motion x-ray, where we move the head around, we take a movie camera picture, fluoroscopy, and then we see, is there excessive movement of the atlas or of the cervical spine. And this is basically what it looks like on MRI. See how you have the foramen magnum here, and then see how the dens is just jamming into the brain. So you could see where it's probably not a good thing to have the dens jam in there. So what neurosurgeons do is they might do a craniectomy here, and then they likely would do a fusion. So they would likely do a fusion there. So sometimes because of the instability, a person needs a fusion. This line right here where the foramen magnum starts is called McRae's line. So McRae's line, the dens of C2 should never go beyond that. When it does, it's called basilar invagination. And then you can do an angle, it's called the clivo-axial angle. So normal is anywhere from like 145 to 160. I don't know if it's, oh, this one says it's 150 to 165, depending on the study. So the more somebody has atlantoaxial instability, and when the dens here starts getting retroverted and goes into the foramen magnum, and that's called basilar invagination. So this is just basically on a CT scan measuring it. So that is a measurement of 145. So you can imagine as this thing angles, the dens angles, and the clivo-axial angle gets smaller, this thing's going to go into the foramen magnum, and that's where you're going to get a lot of symptoms. So this kind of explains when you have basilar invagination, the foramen magnum space narrows, where you got to realize the brain stem's there, the upper cervical spine's there, the cerebral spinal fluid's there, so you can actually get cerebral spinal fluid blocks, and you can get all kinds of symptoms, right? Neck pain, headache, tinnitus, dizziness, vertigo, disequilibrium, cranial nerve palsies, drop attacks, cerebellar tonsillar ectopia, syringomyelia, where there's fluid in the spinal cord there. You can get obstructive hydrocephalus, where fluid accumulates in the brain, so it starts compressing brain tissue, so the brain doesn't function correctly. Now, there's lots of congenital and acquired causes of basilar invagination, including genetic conditions, car accidents, all kinds of things. Obviously, I normally get involved when we don't know the cause, and I think a lot of the cause can just be a simple face down forward head lifestyle, which stretches the posterior ligaments. And once the posterior ligaments get stretched out, the architecture of the neck can change, especially at the cranial cervical junction. Basilar invagination can be life-threatening. So that's why the more severe the case, the more likely a person's going to need stabilization by a neurosurgeon. Early cases, or where the dens is just starting to tilt back, those are the ideal cases for prolotherapy. And again, when you have atlantoaxial instability, you can get kinking of the jugular vein, you can get compression of the vagus nerve. So if you're somebody who's starting to get digestive problems, tachycardia, headache, head pressure, ringing in the ears, consider getting an evaluation to see if there is a structural cause for these symptoms. And if basilar invagination is seen, typically it's a good idea to get a evaluation by a neurosurgeon that's familiar with the condition, as well as an upper cervical chiropractor, and also somebody who is skilled with prolotherapy. Because again, most of us would agree, let's try conservative care, and if conservative care works, that's great, and if not, then of course there's this surgical treatment option for it. And if there's a block in the fluid flow, what happens is a person can get cerebellar tonsillar ectopia or Chiari, where the brain sags into the hole, that also can lead to a fluid block. This illustrates prolotherapy to the atlantoaxial joint, the capsular ligaments there. Typically, depending on the amount of instability found on motion X-ray or digital motion X-ray, the treatment course can be anywhere from 6 visits to 10 visits typically. In some really, really severe cases, it's even more than that. And again, if you have clicking, popping, grinding in your neck, muscle tension, if you found to have basilar invagination, I would get an assessment to see if you have atlantoaxial instability. If that's found, consider getting an evaluation for prolotherapy.